Angiography is a medical imaging procedure that uses contrast dye and X-rays to visualize blood vessels throughout the body. The most common type is coronary angiography, which examines the heart's blood vessels, but the procedure can also be performed on brain vessels, cerebral angiography, leg vessels, peripheral angiography, or lung vessels, pulmonary angiography. Reasons for the test: diagnostic purposes. Chest pain or angina, especially if other tests suggest coronary artery disease, heart attack, to identify blocked arteries requiring immediate intervention. Abnormal stress test results when non-invasive tests suggest coronary disease, heart failure, to determine if blocked arteries are the cause. Valve problems to assess coronary arteries before valve surgery. Arrhythmias when coronary disease might be contributing. Pre-surgical evaluation before major non-cardiac surgery in high-risk patients. Therapeutic purposes, combined with angioplasty, stenting. Acute heart attack, STEMI, emergency angioplasty to restore blood flow, unstable angina, urgent intervention to prevent heart attack. Stable angina with significant stenosis, elective angioplasty to improve symptoms. Failed medical management when medications don't adequately control symptoms. In stent restenosis, repeat narrowing in previously stented arteries. Chronic total occlusions, completely blocked arteries that may benefit from opening. Specific clinical scenarios: unstable angina or acute coronary syndrome. Failed medical management of coronary artery disease. Evaluation for coronary artery bypass surgery or angioplasty. Assessment of previously placed stents or bypass grafts. Congenital heart disease evaluation. Complete procedure. Pre-procedure preparation. Fasting. No food or drink for 6–8 hours before the procedure. Medication review. Blood thinners may need adjustment. Kidney function tests. Contrast dye can affect kidneys. Allergy assessment, particularly to iodine or contrast materials. Consent process. Detailed discussion of risks and benefits. IV access. Established for medications and contrast. During the procedure. 1. Positioning and monitoring. Patient lies on X-ray table. Continuous heart rhythm and blood pressure monitoring. Pulse oximetry for oxygen saturation. Local anesthetic applied to the catheter insertion site. 2. Catheter insertion. Radial approach. Through wrist artery, most common, preferred method. Femoral approach. Through groin artery, used when radial access isn't possible. Small incision made and catheter introduced using Seldinger technique. 3. Catheter navigation. Catheter threaded through arterial system to heart. Fluoroscopic guidance used for positioning. Multiple specialized catheters may be used for different vessel views. 4. Contrast injection and imaging. Contrast dye injected through a catheter into the coronary arteries. X-ray images captured from multiple angles. Left and right coronary systems evaluated separately. Real-time visualization of blood flow through vessels. 5. Assessment and intervention. Cardiologist evaluates vessel narrowings in real time. If significant blockages are found, angioplasty, stenting may be performed immediately. Hemodynamic measurements may be taken if needed. Procedure duration. Diagnostic angiography, 30–60 minutes. With intervention, angioplasty, stenting, 1–3 hours. Angioplasty and stenting. Therapeutic interventions when significant blockages are discovered during angiography. Percutaneous coronary intervention, PCI, commonly known as angioplasty and stenting, can often be performed during the same procedure. What is angioplasty? Angioplasty, formerly called percutaneous transluminal coronary angioplasty or PTCA, is a procedure that opens narrowed or blocked coronary arteries by inflating a small balloon inside the vessel. The term angioplasty literally means vessel reshaping. What is stenting? A stent is a small, expandable metal mesh tube that is permanently placed in the coronary artery to keep it open after angioplasty. Modern angioplasty almost always includes stent placement, as stents dramatically reduce the risk of the artery re-narrowing, restenosis. Why these procedures are performed. Immediate goals: restore blood flow to heart muscle, myocardium, relieve chest pain and other symptoms of coronary artery disease, prevent heart attack or limit damage during an acute event, improve exercise capacity and quality of life, reduce need for medications in some patients. Long-term benefits: symptom relief, significant reduction in angina, improved survival in acute heart attack situations, better exercise tolerance and daily functioning, reduced hospitalizations for cardiac events, enhanced quality of life compared to medical management alone. The angioplasty and stenting procedure. 1. Decision-making during angiography. Cardiologist identifies significant blockage, typically greater than 70% stenosis, assessment of vessel size, length of blockage, and complexity. Discussion with patient about immediate intervention versus staged procedure. Consent obtained for intervention if not already provided. 2. Pre-intervention preparation. Anticoagulation. Heparin given to prevent clotting during procedure. Antiplatelet therapy. Loading doses of medications like clopidogrel. Additional access. May require larger guide catheters. Imaging optimization. Multiple views to plan intervention strategy. 3. Guidewire placement. Ultra-thin, flexible guidewire threaded across the blockage. Various wire types available for different lesion characteristics. Critical step establishes pathway for subsequent equipment. 4. Balloon angioplasty. Balloon catheter advanced over guidewire to blockage site. Inflation. Balloon inflated to 820 atmospheres of pressure. Duration. Typically inflated for 30-60 seconds per inflation. Result. Plaque compressed against vessel wall, opening the artery. 5. Stent deployment. Stent selection. Based on vessel size and lesion length. Positioning. Stent mounted on balloon catheter positioned precisely. Deployment. Balloon inflated to expand stent to vessel size. Post-dilation. Additional balloon inflations may optimize stent expansion. 6. Final assessment. Angiographic result. Contrast injection confirms good flow. Residual stenosis. Typically less than 10% narrowing remains. Complications check. Assessment for dissection, perforation, or flow issues. TIMI flow. Grading of final blood flow through treated vessel. Types of stents. Bare metal stents, BMS. Basic metal scaffolding. Usually stainless steel or cobalt chromium. Lower cost but higher restenosis rates, 15–20%. Shorter duration antiplatelet therapy required, 1 month. Still used in specific situations, bleeding risk, planned surgery. Drug-eluting stents, day. Metal stent coated with medication that prevents tissue growth. First generation, sirolimus, paclitaxel-eluting stents. Second generation, everolimus, zoterolimus-eluting stents. Current standard, third generation, biodegradable polymers, newer drug formulations. Restenosis rates, less than 5–10% with modern day. Antiplatelet therapy, typically 6–12 months minimum. Specialized stent types, bioresorbable stents. Dissolve over time. Limited use currently, covered stents. For vessel perforations or aneurysms. Bifurcation stents. Specialized designs for vessel branch points. Large vessel stents. For left main coronary artery or saphenous vein grafts. Procedure complexity levels. Simple lesions, type A. Single vessel, short lesion, easy access. High success rate, greater than 95%, low complication risk. Procedure time, 30–60 minutes. Moderate lesions, type B. Longer lesions, mild calcification, some tortuosity. Success rate, 85–95%, moderate complexity and risk. May require specialized equipment. Complex lesions, type C. Chronic total occlusions, completely blocked arteries, heavy calcification requiring rotational atherectomy. Bifurcation lesions involving branch vessels. Left main disease requiring specialized techniques. Success rates variable, higher risk of complications. Immediate complications and management. Common issues, 1–5% incidence. No reflow phenomenon. Poor flow despite open vessel, dissection. Tear in vessel wall. Side branch occlusion. Closure of small branch vessels. Distal embolization. Plaque debris traveling downstream. Serious complications, 1% incidence. Coronary perforation. Hole in vessel wall. Acute stent thrombosis. Blood clot in newly placed stent. Emergency surgery. Rarely needed for failed PCI. Stroke. Usually related to catheter manipulation. Success criteria. Angiographic success. Less than 10% residual stenosis. TIMI 3 flow, normal flow, in treated vessel. No major dissection or complications. Procedural success. Angiographic success without major complications. No death, heart attack, or emergency surgery. Achieved in greater than 95% of appropriate cases. Clinical success. Procedural success plus symptom relief. Improved functional capacity. No adverse events during hospitalization. What angiography reveals? Vessel assessment. Degree of narrowing measured as percentage of vessel diameter reduction. Location of blockages. Precise anatomical localization. Collateral circulation. Natural bypass vessels that may have developed. Vessel quality. Calcification, tortuosity, or other abnormalities. Blood flow patterns. Assessment of TIMI flow grades. Clinical findings. Normal coronary arteries less than 50% narrowing in any vessel. Mild disease 50–70% narrowing. Moderate disease 70–90% narrowing. Severe disease greater than 90% narrowing or complete occlusion. Multi-vessel disease involvement of multiple coronary territories. Functional assessment. Left ventricular function through contrast ventriculography. Wall motion abnormalities indicating areas of heart muscle damage. Valve function if contrast reaches heart chambers. Heart rate considerations. Important clarification. During angiography, heart rate monitored continuously. Bradycardia, slow heart rate, may occur with contrast injection. Tachycardia, fast heart rate, may indicate anxiety or complications. Atropine available to treat bradycardia if severe. Hospitalization requirements. Outpatient procedure. Most diagnostic angiograms are outpatient procedures. Patients typically go home the same day. Observation period of 4–6 hours post-procedure. Radial approach allows earlier discharge than femoral approach. Inpatient requirements. Emergency procedures, heart attack, unstable angina, high-risk patients with multiple comorbidities. Complications during or after procedure. Complex interventions requiring overnight monitoring. Planned multi-vessel interventions. Same-day discharge criteria. Stable vital signs. No bleeding at access site. Adequate kidney function post-contrast. Reliable transportation and home support. Ability to follow post-procedure instructions. Post-procedure recovery. Immediate recovery, 0–6 hours. Radial approach. Compression device for 2–4 hours, early mobilization. Femoral approach. Bed rest for 4–6 hours, leg kept straight. Frequent vital sign monitoring. Access site checks for bleeding or hematoma. Adequate hydration to help eliminate contrast dye. First 24–48 hours. Monitor for delayed complications. Avoid heavy lifting, greater than 10 pounds, for 48 hours. Keep access site clean and dry. Report any bleeding, swelling, or numbness immediately. Resume normal medications unless specifically instructed otherwise. First week, gradual return to normal activities. Avoid strenuous exercise or heavy lifting. Follow up with referring physician. Watch for signs of contrast-induced nephropathy, decreased urination. Warning signs requiring immediate medical attention. Bleeding or expanding hematoma at access site. Chest pain different from pre-procedure pain. Shortness of breath or dizziness. Numbness or color changes in arm, leg distal to access site. Signs of infection at access site. Way forward after procedure based on results. 1. Normal or minimal disease, 50% stenosis. Continue medical management, risk factor modification, diet, exercise, smoking cessation, regular follow-up with primary care or cardiologist. Repeat testing only if symptoms change. 2. Moderate disease, 50–70% stenosis. Medical management typically first line. Optimal medical therapy. Statins, antiplatelet agents, ACE inhibitors, ARBs. Lifestyle modifications. Stress testing may be performed to assess functional significance. Consider FFR or IFR testing for borderline lesions. 3. Severe disease, greater than 70% stenosis, or left main disease. Percutaneous coronary intervention, PCI, with stenting. Coronary artery bypass grafting, CABG, for complex multi-vessel disease. Heart team approach for complex cases. Immediate intervention for acute presentations. Post-angioplasty and stenting care. Immediate post-procedure, 0–24 hours. Enhanced monitoring for stent thrombosis or complications. Antiplatelet therapy initiation if not already started. Symptom assessment. Chest pain should be significantly improved. Access site management especially important after interventions. Cardiac enzymes may be checked to rule out procedural heart attack. Essential medications after stenting, as prescribed by the licensed medical professional. Dual antiplatelet therapy, DAPT, as prescribed by the licensed medical professional. Additional medications, as prescribed by the licensed medical professional. Activity restrictions after stenting, first 48 hours. Avoid heavy lifting, greater than 10 pounds, first week. Gradual return to normal activities. Driving, usually safe after 24–48 hours if no complications. Exercise, start with light activity, progress gradually. Sexual activity, usually safe to resume after 1 week. Work, desk job return in 2–3 days. Physical labor may require 1–2 weeks. Follow-up schedule after stenting. 1–2 weeks. Initial post-procedure visit. 1 month. Assessment of symptoms and medication tolerance. 3–6 months. Evaluation for restenosis if symptoms recur. Annually. Long-term cardiovascular risk assessment. As needed. For any recurrent symptoms. Warning signs after stenting. Seek emergency care. Chest pains similar to or worse than before procedure. Shortness of breath at rest or with minimal exertion. Excessive fatigue or weakness. Palpitations or irregular heartbeat. Signs of bleeding, especially if on blood thinners. Stroke symptoms, weakness, speech problems, vision changes. Long-term management after stenting. Stent surveillance. Routine angiography not recommended unless symptoms recur. Non-invasive testing, stress tests, if symptoms suggest restenosis. CT angiography may be used for stent evaluation in some cases. Intravascular imaging, IVUS, October, for complex cases. Restenosis considerations. In stent restenosis, occurs in 5–10% of drug-eluting stents. Timeframe, usually within 6–12 months after stenting. Symptoms, return of chest pain or abnormal stress test. Treatment options. Repeat angioplasty, drug-coated balloons, bypass surgery. Special situations. Need for non-cardiac surgery. Elective surgery. Delay 6–12 months if possible. Especially first 6 months. Urgent surgery. Multidisciplinary team approach required. Antiplatelet management. Complex decisions about stopping versus continuing. Perioperative monitoring. Enhanced cardiac surveillance. Dental procedures. Routine cleanings. Safe to continue antiplatelet therapy. Extractions, surgery. Consult cardiologist about medication management. Antibiotic prophylaxis. Not routinely recommended for stents. Timing. Avoid elective dental surgery in first month after stenting. Pregnancy considerations, as prescribed by the licensed medical professional. Long-term outcomes and prognosis. Symptom relief. Immediate improvement. 80–90% of patients experience significant symptom relief. Exercise capacity. Usually markedly improved within weeks. Quality of life. Substantial improvement in most patients. Medication reduction. Some patients require fewer anti-anginal medications. Long-term success rates. Primary patency. 85–90% at 1 year for drug-eluting stents. Clinical restenosis. 5–10% requiring repeat intervention. Long-term survival. Excellent for elective procedures. Repeat procedures. 10–15% may need additional interventions over 5–10 years. Factors affecting long-term success. Diabetes. Higher restenosis rates, requires optimal glucose control. Kidney disease. Increased complications, needs specialized management. Smoking. Dramatically increases restenosis and stent thrombosis risk. Medication adherence. Critical for preventing stent thrombosis. Vessel characteristics. Small vessels and long lesions have higher failure rates. Long-term management. Dual antiplatelet therapy if stents placed, aspirin plus P2Y12 inhibitor, statin therapy for cholesterol management. Blood pressure control. Diabetes management if applicable. Cardiac rehabilitation programs. Regular follow-up imaging and functional testing. Lifestyle modifications. Mediterranean or heart-healthy diet. Regular aerobic exercise, as tolerated, smoking cessation programs, weight management, stress reduction techniques. Medication adherence cost analysis and insurance coverage. United States costs. Diagnostic coronary angiography. Facility fees. $3,000 $8,000. Physician fees. $1,500 $3,000. Total cost. $4,500 $11,000. Angioplasty and stenting, PCI. Single vessel PCI. $15,000 $35,000. Multi-vessel PCI. $25,000 $60,000. Complex interventions. $40,000 $80,000 plus. Emergency PCI, heart attack. $20,000 $50,000. Cost components for PCI. Stent costs. $1,000 $3,000 per stent. Drug-eluting stents more expensive, specialized equipment. Rotational atherectomy. Imaging guidance at $5,000 $15,000. Extended procedure time. Additional catheter lab time increases facility fees. Post-procedure monitoring. ICU or telemetry monitoring adds $2,000 $5,000 per day. Factors affecting the cost. Geographic location, higher in major metropolitan areas, hospital versus ambulatory surgery center. Complexity of procedure and number of vessels treated, type of stents used, drug-eluting versus bare metal, need for specialized equipment. IVUS, October. Rotational atherectomy. Complications requiring extended monitoring or repeat procedures. Emergency versus elective procedures. Insurance coverage in the U.S. Medicare covers 80% of approved amount after deductibles. Patient responsible for 20% coinsurance. Part B deductible applies. $226 in 2023. May require prior authorization for elective procedures. Private insurance. Coverage varies by plan type and carrier. Typically covers 70–90% after deductible. Prior authorization often required for elective procedures. Out-of-network providers may have reduced coverage. Annual out-of-pocket maximums apply. Prior authorization requirements. Documentation of symptoms or abnormal stress tests. Failed medical management in some cases. Appropriate clinical indications per ACC, AHA guidelines. International costs and coverage. Canada, public health care. Fully covered under provincial health plans, no direct cost to patients. Wait times may apply for elective procedures. Emergency procedures performed immediately. United Kingdom, NHS. Fully covered under National Health Service. No direct cost to patients. Referral through GP required. Wait times variable based on urgency. European Union. Coverage varies by country and system. Generally covered under National Health Services. County payments may apply in some countries. Private insurance options available. Developing countries, India, Thailand, Philippines, etc. Costs significantly lower. $500 $2,000 for diagnostic procedure. Limited insurance coverage in many regions. Government hospitals may offer subsidized rates. Medical tourism destination for cost-conscious patients. Cost-effectiveness considerations. Early diagnosis can prevent expensive complications, heart attacks, heart failure. Outpatient procedures reduce overall healthcare costs. Radial approach reduces complications and associated costs. Preventive angiography in appropriate patients reduces long-term healthcare utilization. Conclusion: angiography, often combined with angioplasty and stenting, represents a cornerstone of modern cardiovascular medicine. This integrated diagnostic and therapeutic approach allows for both precise evaluation of coronary artery disease and immediate treatment when appropriate. The evolution from purely diagnostic angiography to a comprehensive interventional procedure has revolutionized the treatment of coronary artery disease. Key advantages of the combined approach: same procedure treatment. Eliminates need for separate interventions in most cases. Immediate symptom relief. Patients often experience dramatic improvement within hours. Reduced overall healthcare costs. Despite higher upfront costs. Prevents expensive complications. Improved quality of life. Faster return to normal activities compared to medical management alone. Excellent safety profile. Modern techniques have made procedures safer and more predictable. The procedure continuum from diagnostic angiography through complex multi-vessel interventions requires careful patient selection, technical expertise, and comprehensive post-procedure care. Success depends not only on the technical aspects of opening blocked arteries but also on long-term medical management, lifestyle modifications, and patient adherence to prescribed therapies. Economic considerations remain significant, with costs ranging from diagnostic procedures, $4,500 $11,000, to complex interventions, $40,000 $80,000 plus. However, the investment in percutaneous coronary intervention often provides excellent value when considering prevention of heart attacks, reduced hospitalizations, and improved functional capacity. Future directions in the field include improved stent technologies, better patient selection tools, and enhanced imaging guidance systems. The integration of artificial intelligence and advanced imaging techniques continues to refine both the diagnostic accuracy and therapeutic outcomes. Success of angiography and percutaneous coronary intervention should be measured not just by the technical completion of the procedure, but by the improvement in patient symptoms, quality of life, long-term cardiovascular outcomes, and the prevention of future cardiac events. Medical disclaimer: this guide is for educational purposes only and is not a substitute for medical advice, diagnosis, or treatment. Should a medical problem or issue occur, consult a licensed medical professional for advice and treatment immediately. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read in this educational material.